This video is on Dyslipidemia Guidelines by the European Society of Cardiology and the European Atherosclerosis Society, focusing mainly on cardiovascular risk categorization and how LDL cholesterol levels guide treatment decisions. LDL cholesterol is the major modifiable cardiovascular risk factor. It is strongly linked with myocardial infarction, stroke, and peripheral arterial disease. LDL-C reduction lowers cardiovascular events. The key principle behind these guidelines is simple. Lowering LDL cholesterol reduces cardiovascular risk, especially in patients who are already at high risk. The first step in managing dyslipidemia is determining the patient's overall cardiovascular risk category. The guidelines divide patients into low, moderate, high, and very high risk groups. Patients are classified as very high risk if they already have established atherosclerotic cardiovascular disease, such as previous myocardial infarction, stroke, peripheral arterial disease, or coronary revascularization. Diabetic patients with organ damage, such as nephropathy, evidenced by microalbuminuria, retinopathy, or neuropathy, or those with at least 3 major cardiovascular risk factors, for example, age over 40, smoking, or hypertension, are also considered very high risk. Patients with severe chronic kidney disease, GFR less than 30, or familial hypercholesterolemia with ASCVD, or score 2 greater than 20% cardiovascular risk, also belong in this category. These patients require the most aggressive LDL lowering. High-risk patients include those with markedly elevated single risk factors, particularly LDL cholesterol above 190 milligrams per deciliter or blood pressure equal to or greater than 180 over 110 millimeters of mercury. Diabetic patients without organ damage but with a disease duration greater than 10 years, or one additional risk factor, for example, age above 40, smoking, or hypertension, also fall into this category. Moderate chronic kidney disease with a GFR between 30 and 60 and a score 2 greater than 10% also place patients in the high-risk group. Moderate risk patients are usually younger individuals with fewer risk factors. For example, younger diabetic patients, type 1 under 35 years or type 2 under 50 years, without complications and a disease duration of less than 10 years, or a score 2 between 2 and 10%, are generally moderate risk. Low-risk patients have a very low estimated 10-year cardiovascular event risk with a score 2 of less than 2%. The guidelines recommend using score 2 to estimate 10-year cardiovascular risk in adults under 70 years without established cardiovascular disease. For patients aged 70 years and above, score 2OP is used. The guidelines also use the concept of risk modifiers, or risk-enhancing factors, to refine cardiovascular risk. These risk modifiers are not always included in standard risk calculators, like score 2. However, positive risk modifiers reclassify a patient from a lower to a higher risk category and strengthen the indication for lipid-lowering therapy, especially for patients with borderline or intermediate risk. For example, we have a 55-year-old patient with a blood pressure of 135 over 85, total cholesterol of 212, LDL cholesterol of 145 milligrams per deciliter, and HDL of 40. He doesn't smoke and doesn't have diabetes. His score 2 risk comes out to 4.7%, which places him in the medium risk category. Next, we need to check for risk modifiers. His lipoprotein A levels are high. Because one or more risk factors are positive, he will be classified as high risk. The risk modifiers mentioned in the ESC guidelines are family history of premature cardiovascular disease, men under 55 years, women under 60 years. High-risk ethnicity, for example, Southern Asian. Stress symptoms and psychosocial stressors. Social deprivation, obesity, physical inactivity, chronic immune-mediated or inflammatory disorders, major psychiatric disorders, history of premature menopause, preeclampsia or other hypertensive disorders of pregnancy, HIV infection, obstructive sleep apnea syndrome. Biomarkers include persistently elevated high-sensitivity CRP greater than 2 milligrams per liter, elevated lipoprotein A above 50 milligrams per deciliter, above 105, elevated coronary artery calcium score on a coronary angiogram. Once cardiovascular risk is established, the next step is evaluating untreated LDL cholesterol levels. The guidelines categorize LDL levels into several ranges. As LDL levels rise, the need for pharmacological treatment becomes stronger. Lifestyle modification remains the foundation of dyslipidemia management in every risk category. This includes a healthy diet, regular physical activity, weight management, smoking cessation, and optimizing diabetes and blood pressure control. In secondary prevention, meaning patients who've already established cardiovascular disease, aggressive lipid lowering with pharmacological therapy is recommended regardless of baseline LDL levels. In primary prevention, pharmacological LDL-C lowering therapies should be considered in persons at very high risk with LDL-C greater than 55 milligrams per deciliter, at high risk with LDL-C greater than 70 milligrams per deciliter, at moderate risk with LDL-C greater than 100 milligrams per deciliter, and at low risk with LDL-C greater than 116 milligrams per deciliter. Take-home message. The ESC Dyslipidemia Guidelines emphasize individualized cardiovascular risk assessment and aggressive LDL cholesterol lowering according to overall cardiovascular risk.